I'm going to start by talking about the classification criteria we have for gout, or what we can say about them. We will also talk about the methods we use to evaluate the disease, as well as the treatment recommendations for gout at its different stages, as we will discuss later. Regarding the topics, we will talk about asymptomatic hyperuricemia, when treatment is recommended and whether it should be treated, management in patients with moderate liver disease, ultrasound imaging in gout, management in renal insufficiency, and medications to consider. We will begin, of course, by defining what gout is. To do this, we will rely on the 2015 ACR-Euler classification criteria. They define gout as a disease caused by the deposition of monosodium urate crystals in the joints, but also in surrounding tissues. Therefore, it is considered gout when we observe those monosodium urate crystals in a joint. It affects the synovial bursa or a topaceous nodule, which is what we will refer to as a tophus. However, this is not the only way to define what gout is. Numerous classification criteria have emerged based on various factors. Among these, we will see entry criteria used to determine whether a patient has gout and which will be present in all our patients. An episode of inflammation or pain in a joint, whether peripheral or in the bursa. It makes no sense to talk about gout if there is no arthritis. A sufficient criterion for its diagnosis is the presence of monosodium urate crystals, as stated in the previous definition. However, there are other domains that refer to gout-related data, so we could reach a diagnosis of gout, as we will see later, without the need to find uric acid crystals in the synovial fluid sample. It's very tedious to look at the classification table, but at the University of Auckland, they created a calculator to follow the process step by step. All of this domain we mentioned earlier can be navigated just by clicking. You can check it on your phone or just follow along with what I'm explaining. To see how useful this calculator is, we'll start by discussing a clinical case, as it couldn't be any other way. We have a 56-year-old male referred to us from the emergency department due to swelling in his right knee, which at first glance wouldn't be the most common location for gout, but there it is. He presents with erythema, very intense pain upon movement, and an inability to walk. When asked, the patient mentions that he has had about 3 similar episodes in the past. It lasted about 48 hours, and his doctor told him to take colchicine, and that it would help. This is the patient in question, the one with arthritis in the knee, and we perform an arthrocentesis from which, believe it or not, we extract 26 cc, because extracting only the 6 cc noted there from that knee would be a bit odd. So, upon examination, our patient does not present with tophi, and we have a lab result showing a uric acid level of 8.7 mg/dl, outside of the acute phase, from a test done about 3 months ago. Under the optical microscope, we see numerous leukocytes, but no matter how much we look, we are unable to identify monosodium urate crystals in the sample. On the radiographic level, we look at the emergency department X-ray, and it shows no abnormalities, but since we have access to ultrasound, an ultrasound is performed on the affected joint. And we see this image I'm pointing to here, where we first observe a hyperechoic line that corresponds to the bone cortex. And just above it, we see another hyperechoic image that would correspond to a double contour sign. So, if we have followed all the steps of the Auckland calculator, as we mentioned, we will arrive at a total score of around 10 points, which, according to the calculator itself, means that our patient would meet the criteria to be classified as having gout, even though we do not have uric acid crystals identified in the synovial fluid analysis. Gout. We need to understand it as a disease that exists on a continuum. It has different stages. The first stage would be hyperuricemia without clinical or ultrasound abnormalities. So we would refer to it as asymptomatic hyperuricemia. Next, we move on to the phase of gout attacks, in which the patient experiences arthritis or bursitis, followed by a period of intercritical gout during which the patient appears to be asymptomatic. And finally, the last stage we would encounter would be chronic gout or tophaceous gout, in which a poorly managed patient has developed uric acid deposits in the joints. However, we must also mention that there is the possibility of remitting the disease. Gout can go into remission, and in fact, at the last GICAN meeting, which is the American Gout Working Group, they met just before this year's ACR, and we established new criteria to define what remission in gout means. It's a simplification of the criteria that previously existed in 2016, and they tell us that to define gout as being in remission, we need a patient with urate levels consistently below 6 mg per deciliter, which should be measured at least twice in the past year, ensuring there have been no gout attacks during that entire year and absolutely no presence of tophi. The difference from the 2016 criteria is that the pain scores have been removed, which previously required the pain to be minimal, at 2 out of 10 on a visual analog scale, and the patient's global assessment of their disease activity also had to be below 2. To assess the disease itself, we must rely on what we can objectively measure. That would be the analysis of synovial fluid, which, as we mentioned earlier, is the most reliable test for diagnosing gout, but it also allows us to evaluate the disease and observe those uric acid crystals. There are currently studies underway investigating whether the length of those uric acid crystals observed under the microscope has any significance, and later on we'll see where that line of research is heading. Another method we have to assess the disease is the analysis of uric acid levels in the blood, which will be the method we use most frequently during follow-up visits with gout patients. And we'll be interested in keeping the patient's uric acid levels always below the threshold we consider as hyperuricemia, which we'll discuss later. We can also use imaging techniques to assess the patient's condition. We have imaging tests that reveal chronic changes, such as X-rays, and imaging techniques that show more acute changes, like ultrasound. All patients should be included in an ultrasound examination, as long as there is availability of both equipment and time, which in the end will always be our main limitation. Through ultrasound, we will be able to see abnormalities in the Doppler signal, which indicate inflammation. Although this is not something specific to gout, it still provides us with significant value. And we will also see the typical lesions that characterize the OMERACT group, which we will discuss later in the topic. But basically, they refer to tophi, aggregates, double contour, and erosions. Then we have more advanced techniques with more limited availability across hospitals, such as dual energy computed tomography, which allows us to detect uric acid deposits in affected joints in a non-invasive way. However, when it comes to the question of whether there are activity indices for gout, the Siena Working Group, which is referenced down below, developed an index called the Gout Activity Score, which, through a series of items, including the number of gout attacks in the past year, the patient's joint pain, the number of joints with tophi, and serum uric acid levels, establishes a score using a formula that is difficult to apply off the top of one's head. So offhand, they establish a score. This score currently does not have established cutoff points, but there are studies that indicate that by using the Gout Activity Score, those patients with a higher score are the ones who are less well controlled and therefore have a higher level of disease activity. We will now move on to discuss a somewhat controversial topic, the treatment recommendations for gout. For this, we have used the recommendations from the American College of Rheumatology, the ACR. It tells us that gout should be treated when one of these three scenarios is present. When there are recurrent episodes of gout, as long as there are 2 or more gout attacks per year. Right now, this is one of the most debated points, as there are many professionals, especially in our hospital, That's how we do it. They recommend starting treatment from the first gout attack, since if no action is taken after the first episode, it's very likely that a second episode will occur. And what we need to try to do is prevent those episodes of joint inflammation. We would also treat gout right away when a patient has tophi, even if there's only one, and also when there is structural damage. Seen via imaging, whether it's ultrasound, X-ray, or DECT. However, a question arises. Once we have a patient experiencing an acute gout attack and we need to start anti-inflammatory treatment, the question that always comes up is, should I give it to them? Anti-inflammatory treatment, but what should I use? Colchicine, anti-inflammatory, non-steroidal, or a corticosteroid? Well, the studies tell us that in these three scenarios, thank you, there is a preference for one treatment over the others. In patients over 65 years old, the use of systemic or intra-articular corticosteroids is recommended. In patients on anticoagulation, the use of oral medication is recommended. However, it must be said and made clear that being on anticoagulation is not a contraindication in any case, neither for an arthrocentesis nor for an injection. You just need to take extra precautions. And what about rest and compression measures? After an injection or arthrocentesis, more care should be taken, but it is by no means a contraindication. In cases of chronic kidney disease or transplant, treatment should be carried out using systemic or intra-articular corticosteroids rather than colchicine or anti-inflammatories due to the kidney disease, chronic. And in those patients for whom we can't administer any of these three medications, which would already be more exceptional cases, well, the use of interleukin-1 inhibitors, such as anakinra, is still approved for this group of patients. Now then, based on the important article published in The Lancet in 2021, in which Avisek and Nicola Dalves contributed, they discuss with us which medications we should use, both oral and intra-articular. And they tell us that there is equivalent efficacy among the oral medications, such as prednisolone, NSAIDs, or colchicine. However, the preference for using one over the other is not based on efficacy, but rather on the safety profile. Therefore, they recommend using corticosteroids over NSAIDs and NSAIDs over colchicine during the acute phase. And the recommendation is to use intra-articular glucocorticoid in cases of monoarthritis. After having defined how a gout attack should be managed, we must begin to treat the patient in the long term. We usually focus on the last two columns and explain to the patient during the consultation how to prevent flare-ups, how colchicine should be taken, and how to start urate-lowering therapy. However, we always forget about the first two sections. It is very important to help the patient understand their disease and what is happening to them, what their disease consists of. This will improve adherence and compliance with treatment and follow-up visits in the clinic, and also address dietary questions, since patients often impose dietary restrictions on themselves that, with proper explanation and by providing all the recommendations, we could help them avoid. Regarding the prevention of flare-ups, it is done with colchicine maintained for at least 6 months. And that's what this article by Nicola Dalves tells us, in which they made a comparison in patients who had started urate-lowering therapy with a start low, go slow strategy, whether it is necessary to give colchicine to these patients or if they can be managed with placebo without gout flare-ups. And it is observed that those patients who received placebo had an increased number of attacks compared to those who received colchicine. Therefore, the current recommendation is to maintain it for at least 6 months when starting rate-lowering treatment. Those two pillars I mentioned earlier are very important because of this chart I'm showing here, which highlights that 1 in 2 patients with gout doesn't know that it's a disease that can affect both men and women. 6 out of 10 believe that it only affects the feet or toes. 4 out of 10 believe it's a disease that comes and goes. And 6 out of 10 don't know that it's a type of arthritis. Here on the right, we can see a food traffic light chart, categorized by higher risk of triggering gout attacks. This chart visually represents food items categorized by their potential to trigger gout attacks. Beer, in particular, is highlighted as a high-risk item. Beer is something we really need to emphasize to patients that they should limit their consumption of as much as possible, because the food or drink, in this case, that is most strongly associated with the increase in uric acid due to diet. Regarding uric acid lowering treatments, the current strategy being used, and the one we should all be using, is the start low, go slow approach, beginning treatment at a low dose and gradually increasing the dosage. On the podium of commonly used medications, we have first and foremost, of course, allopurinol, a xanthine oxidase inhibitor. The recommended starting dose is a 100 milliliter per day, and it is advised to gradually increase the dose. At most, every 14 days. It is not recommended to increase the dose on a weekly basis. The maximum dose in Europe is 900 milligrams, whereas in the United States, the maximum recommended dose is only 600. If allopurinol cannot be used, the second option on the podium would be febuxostat, another xanthine oxidase inhibitor. The initial dose, according to the prescribing information, is 80 milligrams per day. However, it is usually started at 40 milligrams, half a tablet, because it lowers uric acid levels faster than allopurinol. Therefore, anything that acts quickly would go against the first part of the current therapeutic strategy used for gout. Then, to mention other drugs now used only marginally, we have, for example, benzbromarone, which is a uricosuric agent. The recommended starting dose is 50 milligrams and the maximum dose is 200 milligrams. It has a hepatotoxic effect here, which we will discuss later. Among other drugs not shown on the slide but also used, one to highlight is the Provençin. Two interesting facts about probenecid. One is that it was a drug historically used during World War II to guarantee the supply of penicillin. Since it significantly increases plasma levels of penicillin, the dose required can be reduced. And through a completely different mechanism, probenecid is also used in a doping substance because it enhances the elimination of toxic substances from the body. Therefore, if probenecid is detected, it will result in a sanction for those athletes.